Welcome to Black Health Matters. I'm Darryl Armistead, your host. This episode is a Zoom recording of Howard University group session led by Dr. Clive Callender.
So many things are happening. Well, you might as well look at some of the positive things. This is a 6-year-old who's the youngest member of the Mensa Society, which is a society for people who have high IQs. And having precocious kids is quite a challenge. And it's just beginning for her at 6 years old. Yeah. IQ 137. Sometimes you wonder if that's a curse or a blessing sometimes. With the right parents, it's a blessing. With the wrong ones, it can be a curse. So it's going to be interesting how this works out. There's such a desire to promote kids, just like Darryl was a child prodigy as well. You never know how people like that are going to turn out. Some of them turn out to be fabulous people, like Darryl, and you have others who just never quite adjust. And what makes a difference? I'm not sure I know. Darryl, you got any thoughts on it, being one of those in that category?
Well, yeah. Even though you might have precocious kids, they're all different. Some of them, just like a kid of any intelligence, some need more discipline than others. And so there's no general roadmap to deal with precocious children. The only thing I would say that's it's important. They get bored, and so it's important to challenge them and not let up off the gas.
Tatum, how are you dealing with your 14-year-old grand prodigy? John Tatum?
The thing I did was I took him to see a super piano player, Mr. Levy, to give an evaluation on his piano skills and everything. Mr. Levy is a monster piano himself, piano player, and he knows jazz real well. So he gave him some pointers. So my answer is that you take him to the best of the best to get pointers.
So you're kind of saying what Darryl said. You challenge him, huh?
Yeah.
Mm-hmm. Okay, well, let's go to the next one. Any other comments about this? Because many of us have those kinds of children. I don't.
What was the name of this? What was the name of this article again? I'm sorry.
The article was about this 6-year-old who's a member of the Mensa Society is a high IQ, and we were talking about how do you deal with people who are like that and it's gifted, just like your son. John was talking about your son, I think.
Yeah, Markai. Tell him about what you're doing for Markai.
Right.
Mark.
So I do agree with Darryl that challenging him is a challenge for his mother and I, just to keep him occupied and busy. in all honesty, I don't think he ranks. He's not. He wouldn't be considered a prodigy. He is very good. He is very talented, and he's highly intelligent. But the category of being a prodigy, that's the next level, which he's not exactly. But he's still someone who's very intelligent, and we still have to stay on our toes to keep him busy.
Okay, let's go to the next one. This is an interesting saga of when you encounter adversity, the question is, do you run and hide, or do you go and give it your best shot at trying to get things better? And this nurse could easily have continued on her way, but she saw a problem and she tried to do what she could to save this person's life. And as a matter of fact, she actually put on a tourniquet that actually saved this guy's life. But she could easily have kept going, but she didn't. And she saved this guy's life. You know, whenever those of you who drive, you see people in accidents, the question is, do you try to stop and help them, or do you just continue going on your way? And those who have some medical backgrounds, it's probably a good idea to see if you can help out. Those who don't, well, you can call for help for somebody. That may be the best thing you can do. But this is an example of a nurse who risked her life to see if she could help, and she wound up really helping. That's interesting. You tell me you're not dying today. Yeah, a lot of nerve. But lo and behold, they were able to save him. Yeah, it's being at the right place at the right time can make a difference for people. It's amazing. So many ways you can be a blessing in this situation. That accidents can happen to anybody. So, it's such a joy to see stories like this, because we see all these negative stories all the time. It's nice to see something positive about how we care for one another and look out and try to be helpful. Because that after all is one of Christ's greatest teachings. Love your neighbor as yourself. And lo and behold, that's what this lady did. And stop the bleed, which is something that is the country is becoming familiar with, is something very simple that you can do, and it can save somebody's life. And there's so many good people in the world. We got bad people too, but there's so many good people in the world. It's good to hear about these stories where people who can make a difference do make a difference. And so in this world, we see so many things about war and killing and all of that, and violence. So to balance it off, it's good to have some stories that talk about how people took the time to care and use their talents to help somebody else. Any other comments about this nice story? Do many of you know about Stop the Bleed? Have you heard of that before? It's a program in which they educate people about putting on tourniquets, because when people start bleeding, if you put on a tourniquet, it may stop the bleeding. And of course, in this case, it saved this guy's life. And there are many people whose lives can be saved by something as simple as stopping the bleed by putting on a tourniquet. Any other comments?
One comment that I would like to make, is unfortunate in our society. Negative news sells better. Newspapers, magazines, and stuff, they make more money by selling bad news. So you're right about the fact it's good to hear about a good story every now and then.
Yeah, and it may well be that the good stories may be more frequent than some of the bad stories, but as you said, they don't sell as well as the bad story. But okay, let's go to the next one. Yeah, this is an interesting story about how to take care take, take care of high blood pressure. There's so many. That's one of the biggest problems in treatment of high blood pressure is medication non-compliance. That is, they're not on the right medication or not taking the medication. So many of the situations we encounter, as Joyce would tell you, is that people know they have hypertension, but they aren't taking their medicine like they're supposed to. And so it becomes important there.
Dr. Callender, you got muted.
Yeah, so it becomes important to not only have the right medicine, but to take the medicine when you're supposed to take it. Some people are supposed to take it twice a day, sometimes 3 times a day, and sometimes 4 times a day. But if you don't monitor the blood pressure, and if the blood pressure is not controlled, then it's a waste of time, because the real deal is to keep your blood pressure under control so that it's under 130/80. And if it's there or under that, then your blood pressure is controlled, and therefore you don't get the complications of hypertension, which are so many: heart attack, stroke, and heart failure. So it's good to hear stories about the fact that sometimes community groups and others are actually monitoring their own blood pressures. I think in the self-help groups in which the patients play a major role in handling their blood pressure makes a big difference. And if you have a blood pressure monitor and you take your pressure probably about twice a week, and you know that your blood pressure is less than 130/80, then that, of course, is great. And
Dr. Callender,
yes,
how do you know? I mean, when you're taking medication for high blood pressure, how do you know when to? I mean, if you're monitoring, how do you know when to stop taking? I mean, that you can get off your medication. How do you know? I mean, if you're taking it and it's regulating your pressure, how do you know
well, you should
when's
stay
the
on
best
it.
time you can come off?
Well, I think for the most part you should stay on it until, and if the medicine is keeping your blood pressure normal, then you should stay on it.
Mm.
And that's the question she asks is a very good one, because the presumption is that you get to a point where you don't need the blood pressure medicine any longer. I'm of the opinion that you should stay on the medication as long as the medication controls your blood pressure. So that I'm not thinking that you should be off the blood pressure medicine. However, if you get to the point where your blood pressure is too low, then you might consider stopping the blood pressure medicine. But to me, the goal is to keep the blood pressure normalized, and that means that if it's normalized, then you should continue taking medicine. Because what happens is people who come off the medicine, if they don't monitor the blood pressure may become high again, and then they aren't monitoring it, and therefore they suffer the complications of uncontrolled high blood pressure. So my philosophy is that uh, I wouldn't aim for eliminating the blood pressure medication, but rather to normalize the blood pressure and continue taking the medicine, keep it controlled. Any other comments or questions? Because that's a question that has a number of ways to answer it.
Yeah, that's a good point that you made, Dr. Callender. The other thing too is you mentioned if the blood pressure is consistently low after you take it, then you can talk to your doctor about making some changes.
That's correct.
And then the other thing too is that there are some other things like exercise. I know that's a powerful word. That can help to lower your blood pressure. So if you have a new routine where you increase your exercise routine, you can bring your blood pressure down. Then you still have to talk to your doctor and say, look, I am beginning to do more exercises and I'm doing a bike every day and this and that and the other. And I've been checking my blood pressure. It seems like it's coming down. So, doctor, you think this exercise is helping my blood pressure stay a little bit lower?
Well, it is helping, but that doesn't mean you should come off your medication. But if it does get too low, then you lower the amount of medication, and at some point you may be able to come off of it, because losing weight and exercising are ways in which you can better control your blood pressure. Any other comments about it? Because this is one of the most important sources of mortality and illness, hypertension, and diabetes, the two big killers. Okay, let's go to the next one. Now, this is an article that I thought was very critical because, one of the things that bothers me is that developing countries really have vaccines to the extent that many of the people are able to get it. Some of the rich people get it, but others don't. And so to have a alliance that's willing to commit $1 billion to manufacture vaccines in Africa is great news. And it's hopeful that by 2040, they'll have 60% of the vaccines needed. That's good news, although it'd be nicer to have 100%. But the fact that when we talk about vaccines, that the developing countries often don't get those vaccines. And so having somebody to commit this kind of money to manufacture vaccines in Africa is welcome news.
Dr. Callender, do you know anything more about this vaccine alliance? Where are they located and what
No,
their
I don't. No, I don't. I never heard of it before I saw this article.
Gavi?
But I guess Bruder may have more details on it. But I hadn't heard of it before. It's welcome news to see that somebody is caring about the developing countries. One of the things that I've always worried about is the fact that sometimes we get the vaccines in the developed countries, but the developing countries don't get it. So this is you can see the amount of money we're talking about, and that's the kind of money that you need to have to take care of vaccines for developing countries.
I just saw on the news that Pfizer stock is like way down post pandemic. They're not selling the COVID vaccines like they were, and they're losing money.
Well, losing money is a relative term. All the billions they made from the pandemic, uh, they can afford to lose a couple of billion.
I hear you.
The other thing is that the other companies who develop vaccines, now competing. I got Moderna the other day. At first I was on Pfizer, but now I moved to Moderna, so they lost some of my money.
Okay, well, we've got some more articles on the vaccines and how the infections are piling up. This is an article that talks about, are your organs aging well? And as you age, there's blood tests that can tell whether your kidneys, your heart, your liver, your lungs are aging. We've learned that the mitochondria and telomeres are part of the cell makeup that determine how long you live. And so if the mitochondria are slowing down, if the telomeres are shortening, then there are blood tests that can tell. You look at the BUN, the creatinine, and some of the other blood tests that are done for each of the organs, and they can tell you whether you're aging. Well, we know we're aging. The extent to which your body is handling the aging process.
Yeah, the speed of your aging.
And we now know that there are compounds that increase as you age, and they affect the genes as well as the mitochondria and the cell. And these, for example, they have taken older organs and given them to younger people, and taken younger organs and given them to older people. And they found that there's a difference, and that there are senescence age factors that when they're present, they cause deterioration of the mitochondria and the genes and the telomeres. And so if you took a young person's blood and gave it to an older person, and same thing is true of some organs, this then would decrease the amount of senescence or aging that occurs in the older person. And so as we learn more about this, we will identify those compounds that cause aging to accelerate, and those compounds that cause aging to slow down. And this is one of the things that getting your blood tests once a year will give an idea as to what's happening. As we know more about these so-called senolytic agents, that is, agents that decrease the aging of cells, then we will be able to perhaps allow us to live longer. But it's good to know that at least we're making some progress, because there's one compound that has reduced by 50% the rate to which the cells demonstrate their aging.
Can I get some of that?
Well, they haven't marketed it yet, but they're working on it. And one of the things, for example, they're doing a lot of studies because they found out that aging is something that can be reduced, but identifying and producing it on a large scale is not something they've been able to do yet.
Dr. Count, I have a question. The other thing is that as far as aging, do the organs have separate aging processes? You know, maybe.
Yes,
Okay.
yes, they do. And apparently there's a lot of research going on that identifies that there's crosstalk among the organs in which the organs that aging produce factors that may affect other organs. And this crosstalk may be disastrous if you don't have the ability to overcome the negative aging factors. They call them senescence secretory proteins. And the senolytic, or the compounds that reduce these aging agents, are ones that allow for the mitochondria and the cells to thrive again rather than to slow down their metabolism. And this is something that is occurring, thus getting a lot more information. Just recently, last month, I think, they came out with a couple of articles that identified that for organ transplants, for example, that the younger organs would, if you use younger organs for older people, that it would be beneficial.
Dr. Count, I think we have a new member that just joined us, Claude F.
Hey,
Like to say,
hey John,
welcome.
how are you? How's everyone?
Welcome. Glad you could join us today.
Thank you.
And speak up if you have any questions or any comments at any time. Welcome to the group.
Thank you, sir.
Okay, any other questions about the aging process? You know, Ponce de Leon once was looking for the fountain of youth, and it seems as though we're identifying some factors that will slow down the aging process. Time will tell.
I had one other question, Dr. Callender. You talked about it's beneficial if you can use a younger organ into an older person. Now, I know that UNOS had some regulations. Talk about the opposite of that. What about using an older organ in a younger person?
Well, we know that if you use older organs in a younger person, that the older organs are more likely to be rejected. So there is a finding that has been demonstrated over time that there is a benefit of using younger organs, and there's older organs are more likely to be rejected than younger organs. Whereas older people are less likely to reject, their organs are more likely to be rejected. And this then means that there are factors that these older kidneys or organs are presenting that if they are modified, that could be overcome. But so far, we had not been knowledgeable about it, and as a consequence, we were using older organs for anybody, and we're now recognizing that there are some deleterious effects that occur when older organs are given to younger people.
Yeah, because on that same point, they were talking about dire circumstances of using an old organ just to save someone's life, if of course, like you said, if it wasn't rejected.
Oh yeah, and of course it will save somebody's life. It's just that the complication rates are greater when older organs are used. That's
Thank
all.
you. Thank you.
As you know, as time goes by, we learn so much more about other aspects of life, so we have to make those changes. And soon we'll be able to treat those older organs with substances that will knock out the negative aspects of the older organ. But we now are aware, which we weren't aware of before, that there are negative consequences to using older organs. Okay, next article. This is some great news. Sickle cell patient success with gene editing raises hopes and questions. Actually, the good news is that of 32 patients who were treated with gene editing for sickle cell disease, 31 were associated with great results and not having crises. So this CRISPR Cas9, which is the gene editing, actually did work, and as a consequence, many of those patients, 31 of the 32 patients who were getting 3 to 4 crises a year, wound up with having either one or no crises. And there were 2 genetic modifications that were done. One was that allowed for fetal hemoglobin rather than the defective S hemoglobin that caused the clotting. And so the gene editing that allowed for the relatively normal hemoglobin to replace the sickle cell hemoglobin made a big difference. And this is just recently approved by the FDA. So while it's not been used in the past, and while the question is how expensive is it, this is issue will now come to the fore since FDA has approved it for use.
Dr. Callender, will the price come down? Because I know it's prohibitive. Over the years, once they perfect the technique.
The expectation is that is the case right now. It's going to be exorbitant. You're right. And of course, the people who are using experimentally don't have to pay for it. But once the FDA approves it, then it's a different story. And the painful crises that these patients go through is something only if you endure it that you understand it. Our president of Howard, Wayne Frederick, is a sickle cell patient, and he has 1 or 2 crises a year, and there's some patients that have 4 to 6 crises a year, and the pain is such a magnitude that they need opioids to help. Now the question is, how costly is it? And that is the question. And this is the article that shows that FDA has now approved it.
Dr. Callender, what is the opioid of choice for the sickle cell patient?
It varies from patient to patient. Morphine or Dilaudid, whatever works. It varies from patient to patient. But they are addictive. That's the problem. the medications are addictive. They were just given the Nobel Prize for this work 2 years ago, I think it was. And this is the second process that use a virus to go into cells and change them so that they produce a different type of hemoglobin. See, the wholesale price 2.2 million. This is 3.1 million. So, so who can afford that? But you know, just as you mentioned, as they learn how to do things, the price decreases. But the negative aspect of it is that who has that kind of money? Those patients who are doing it for experimental purposes, they didn't have to pay any money. But now it's FDA approved. What's going to happen? What's going to happen in developing countries that don't have it? Also, the gene editing treatment is becoming, as you mentioned, is becoming simpler. One of the things we don't know, what is the downstream effect of doing this gene editing? We don't know. We'll have to wait and see. But it's a process that is taking us forward. So it's just progress. It's progress.
Dr. Callender, I thought it was interesting that not only Black people have sickle cell, but also some Southern Italians, um, dark complected Caucasian people also
Right.
have it. North African and Southern European.
Yeah. It's just that about 90% of the people who have it are Black people. And this is good to see the understanding of this and the success of this to come to the fore, although the price is frightening. And then, of course, after you use it on a large scale, you'll be able to find out what are the other downstream effects with gene therapy.
So, Dr. Callender, when a child is born that has sickle cell, they get it directly from both parents? Both parents have
Yes.
to have it?
Yes, yes.
Okay. And then, but if you can have the trait and not have the disease, I think I remember.
When you have the trait, you only have one parent who has the sickle cell gene. And you have the disease, both parents have the sickle cell gene. And so if two trait people marry, then it's a problem. Or if two sickle cell people marry, it's a problem. So
I was thinking about the child, the baby. Do they have crises right from birth?
no, usually it starts probably about 2 years old, and yeah, because I remember that when Wayne Frederick was talking about his diagnosis, it was made when he was very young, and they didn't think that he would live, but he did. But they start having crises very early, sometimes under 5.
So it looks like we're on the way to a cure.
Yes,
That's good.
yes. Actually, bone marrow transplantation has been 95% successful as well.
Oh.
So that was already in place, but CRISPR-Cas9 is more expensive right now, but down the road, as you say, maybe it'll be less expensive. Now, John has included this because I wanted to point out that 3D printing in tissues is still going on, and the hope is that eventually we'll be able to use that for organ transplants. Tissue transplants, 3D printing is already being used for bladders, but not for solid organs successfully yet. And this is the article we talked about before, that about the fact that we have vaccines now in the process in developing countries.
So, Dr. Callender, when they use 3D printing for organs and tissues, what material are they using?
They're using endothelial cells. In the case of the bladder, they use the bladder cells. But for the whole organ, that's a problem because you have to have layers of endothelial cells as well as other cells. For the liver would be a problem. Kidney, because it's such a complex system for kidney and liver, and that's why the 3D printing so far has not moved fast enough for the complex organs. For tissues, yes, for skin and tissues and bladder, it has been used effectively, but not for the organs yet.
Thank you.
Not to even mention the heart. And we're way, way from that, I guess.
Well, actually, the heart is not as complex as the kidney and the liver. The heart is just a muscle, but it has nerves as well. But it'd be easier to do the heart than it is to do the kidney and the liver, because the kidney and the liver are so complex. The liver has so many functions, and the kidney has so many glomeruli and other things that make it up, that it's going to take a while for us to be able to do that. But we're in a situation where we have a beginning of understanding of how genetic reengineering and stem cells will make a difference.
Do I dare mention the brain?
Say again?
What about how complex would it be for the brain?
That's right now out of the question.
Okay.
We haven't been able to do anything with the brain. We do some things with the nerves, but so far the brain has escaped our attempts. That may be the most complex organ of all. This is an article that talks about our immune system and how we respond to different COVID variants. in how our antibodies mature over time, and how this allows them to deal with the variants of the different viruses, how they just grow and grow and grow. And it's amazing what the immune system does and how they're able, just like John had mentioned before, how many antibodies you have and how they're able to adjust and destroy most of the foreign invaders. And there are so many. And so the vaccinations that we get help us in having the antibodies be responsive to different viral variants.
Dr. Callender, I've heard that different blood types would determine the outcome of a COVID infection. Is that true?
Well, I think blood type alone will not do it. We've also identified that some blood types are better able to deal with COVID than others. We've also identified that there is an interferon which allows the immune system to knock out COVID. But there are people who have antibodies to interferon, and those people who have antibodies to interferon are the people who are likely to die from COVID infection. So what we would have to do is to have competing antibodies, because what I'm saying is that the normally interferon is a substance which protects us from infection. But sometimes we have autoantibodies that prevent our interferon from being effective. So in order to overcome that, even more than blood type, is to have an antibody against the interferon antibody, which will allow our normal immune system to destroy the COVID. But there are some studies that suggest that there's a difference between A, O, and AB and their response to COVID. But I think the greater impact is that which is associated with the interferon antibody, which is protective. But when you have a substance that prevents the interferon from being effective, then one of the treatments is to knock out that substance so that you can overcome the infection. Of course, the ultimate is the vaccination, which gives us the greatest opportunity to overcome the COVID infection.
Thank
So
you.
the answer is yes, there is a difference, but a greater difference is related to the antibody production of interferon and other protective substances.
Dr. Callender, I did my 107th blood donation yesterday at the NIH, and there's a big push now for blood donation. That if anybody's able to donate blood, it would be highly appreciated. And you know, the talk about the human immune system. I remember Dr. Atto and I were at the NIH studying the immune system, I guess, probably 25 years ago. And
Long time ago.
it is, I mean, back then the immunology textbook was like 3 inches big. Now it's twice as big.
That's true.
Because of the advances that we've made. the human immune system can identify and respond to trillions of different structures and can mount protective responses to an unbelievable number of invaders. So it's fantastic, and it's beautiful. But also, if it gets sidetracked, we are definitely in danger. Just like, I mean, right now we're at war. We're at war with viruses. So thank goodness for the immune system.
So, John, are you saying we are endangered species?
Absolutely.
Well,
Absolutely.
what protects us is our diversity, and that's one of the things that we all have to recognize, that diversity begets ingenuity, and the diversity of our immune system is what helps us win the war, as you say. And the more diverse we are, the better off we are at fighting off these different infections.
May I ask a question, please? Slightly off topic.
Sure.
Okay.
Go ahead.
I'm a survivor of bladder cancer, and had my bladder removed back in the early 2000s, and rebuilt out of my bowel, out of my intestines. And now I'm suffering from kidney disease. And I was with my urologist a couple of weeks ago. I just want your thoughts on this. And my numbers now are around 33, 34. And we found out that after he did some blood work, my urologist, he found I had a urine infection. And we often talk about my kidney disease. So he said, he mentioned, he said, Claude, since you're, he said, let's try something. He said, your bladder now is made out of your intestines, and it has a tendency, I guess, to control bowel. So he found out that I had this UIT, and he said he might think that the causes of my numbers going down, it might be because of this infection. So he put me on 500 milligrams of amoxicillin for 5 weeks, and he wants me to come back at that time and see if my numbers has changed at all. What are your thoughts on that?
I think it's worth a try.
Yeah.
You said your numbers. You said you're talking about the BUN is 33. Is that what you said?
Yes, sir.
Oh, okay. Yeah. Okay. Well, I think it's worth a try. And because you're still at the point where your kidney function is still, it's not normal, but it's not so bad that you. I mean, BUN of 33 will not cause you any symptoms at all.
Mm-hmm.
But it is a sign that you do have kidney disease, but it's kidney disease that may perhaps be reversible, and that's what he's trying to see if cutting out the infection may decrease your kidney function, may increase your kidney function. And the only way you can do that is to try with the antibiotics and see what happens, and then based upon that, decide what the next step would be.
Thank you.
But it makes sense. Yeah.
Thank you.
Any other comment or questions?
That was a good question. That was a complex question.
Yeah.
Good.
Yeah. We talk a lot about colon cancer, and we know that the reason we do colonoscopy is to remove any colon polyps that appear, because they may eventually turn into cancer. Not all colon polyps are cancerous, but all colon cancer starts off as a polyp. So, so the colonoscopy is done to take out any polyps that occur. And so the question is, how do you know that you have polyps? Well, for the most part, early on, they are asymptomatic. And so you wait till they are associated with symptoms, and that's not good. Adenomatous polyps are the commonest to become cancer. These polyps, hyperplastic and inflammatory, are not usually cancerous, but still should be removed. Now these are the sessile polyps, and I know I once had one, have a higher risk of cancer. The sessile, but they are whenever you find any polyps, they should be removed. Blood in your stool or rectal bleeding is a sign of a irritated polyp. Anemia may occur because you have a polyp that's bleeding. Diarrhea or constipation may also be associated with polyps, as well as unexplained weight loss. Those are some of the things that you may see if you have a polyp. Any abdominal pain or discomfort may be associated with that. And then if you have anemia, which causes fatigue and weakness, this also can be a manifestation of rectal bleeding. So anemia can give you shortness of breath as well. Again, though, waiting for symptoms of polyps is not a good idea. But if you have any of these symptoms, you should be evaluated to determine whether you have colon polyp or not, because colon polyps are the first phase of what may be cancer.
Dr. Callender, case in point, Carol and I know a person lives right down the street who was consistently having stomach aches. And it's a man. And so he didn't go to the doctor right away. Because that's our reputation. But anyway, once he went and had his colonoscopy, not only did they find 7 polyps, but they found a lesion that was cancerous. So this article is right on. I'm gonna make sure his family members can see this.
Thank you. Any other comments? If not, very helpful article. Now, this is an article that is more of a hopeful article than it is a reality, because the studies are far too early to draw any conclusions. But this is about the vaccine for melanoma, which is the deadliest form of skin cancer. And what they did was, at the time of removal, they also gave them a vaccine with the hope that it took out the cancer, and the hope that the vaccine would keep the melanoma from recurring. Now, it's kind of early, but so far, the suggestion is that most of the 50 people who had surgery, 50 received the vaccine. And the melanoma returned in 22% of those patients within 2 years, compared to 40% in the control group, which suggests that this may perhaps be a vaccine that may help prevent or delay the recurrence of melanoma. But anyway, so it's data that's encouraging. It's not enough to say that it's a breakthrough, but uh, it's worthy of being aware of things that are happening. Of course, the desire to do something with pancreatic cancer as well, because cancer, melanoma cancer and pancreatic cancer both have high mortality rates. And so there's hope that this may turn out to be of merit, but it's too early to tell. $18 months is not very long. Same thing is true for this breast cancer vaccine. And we all know that breast cancer kills far too many women. 42,000 women a year die from breast cancer. And we have so many of our young female surgeons who die of breast cancer. So you want to try to find a way to prevent these deaths until they develop this vaccine. But again, it's much too early to tell. I think we reported on this some time ago. She's the first woman to get the breast cancer vaccine, but whether or not this will be the beginning of something that's very special remains to be seen, but certainly it's worth a try. So we include this just to show that just as we see the cure for sickle cell disease with the CRISPR-Cas9 gene editing, well, down the road, this may be the beginning of something that turns out to be a vaccine that will prevent cancer from recurring. One of the problems that we have is we don't really understand what cancer is. And the idea that cancer may be an infection of some sort that can be prevented by a vaccine is an interesting idea, and time will tell. But so many women die from it, it's certainly worth a try. One of the things we tend not to talk too much about is the association of dental caries with heart disease, stroke, and death. And many of the studies now are demonstrating that the bacteria that are found in the mouth that go along with caries carries with it an increased risk of stroke and death and heart disease. And so taking care of your teeth may be the first step in preventing stroke and heart disease. So I guess the moral of the story is that we need to be sure we go to our dentist and keep our teeth clean and get the caries taken care of, because the infection in your mouth may lead to increased risk of stroke, heart disease, and early mortality. So don't neglect your teeth, your mouth. How many of you actually go to the dentist? Yeah, about every 6 months or so. And taking good care of your teeth is very important. Now, here we go again, huh? The CDC director is now asking us to mask up again. And why? Because COVID hospitalizations are killing people. And so as you go to church and you go to public places, the triple-demic is here. And the wearing of masks is requested again. I hope by now everybody's gotten the 3 vaccines, RSV, the COVID, and the flu virus, because we're right in the middle of the flu season. Between December and February is the peak of the respiratory illness syndrome.
Dr. Callender, did we forget about the common cold?
No,
I mean, is there any research being done on vaccines for the cold? Because I caught a cold coming back from Mexico.
well,
I tested every day for COVID. It was not COVID, but it was a cold. It was annoying, but it wasn't life-threatening.
well, that's the difference. The cold is not thought to be associated with hospitalizations and death, whereas the other 3 are associated with hospitalizations and death. And so that's why and I guess that's one of the reasons why they don't have a vaccine for the common cold.
But it is a virus, though, right?
Oh, yeah. Yeah. But it's just not associated with the hospitalizations and deaths that are with the other 3 are associated with.
Dr. Callender, are all the hospitals being overrun? I mean, are they all filled to the capacity?
I don't know the answer to that question, but you will see a couple of our reports that identify that it is getting to that point. It's not at that point yet, but it is likely by the end of the month that will be the situation.
Okay, because my sister-in-law is in the hospital. But one doctor, well, I've met a doctor and a nurse, and they go from one hospital to another. One said they've been at Sibley, one said they've been there, and then they come to the University of Maryland Capital Region Hospital. And I was saying, wow. But they were saying all of them, all the hospitals they've been to, there's not enough rooms for all the patients. So people have to stay in the emergency room until there's 2 or 3 days until it's opened up. And I was just wondering, was that really true with all the hospitals in this area?
I don't know the answer to that question.
Okay.
This article goes along with what John Buchanan was asking about. Most of those with coughs are thought to be related to these 3, but we still have the common cold. And this is the adenoviruses that what John was talking about. And we have tests for most of the other viruses, but most of the rhinovirus and the adenoviruses are not often tested for. Question is, how long are you contagious? If you're coughing, if you bring up sputum and it's yellowish or brown, it's probably associated with the adenoviruses, and it can be contagious. And here they're talking about the antiviral medication that we have for the flu. And this is talking about how we we symptomatically treat colds and coughs. I don't know. I would not recommend corticosteroids or any of those things because it weakens your immune system in addition. Of course, the best advice is said here: if you're sick, stay home. And if you must go out, wear a mask so you can protect others from you and you from others. Any other questions about this? Comments?
I went to a basketball game last night at the Capital One Center, and I kept my mask on the whole time, being indoors.
Who
And
was playing?
the Pelicans, the Wizards of the
Oh,
Pelicans.
oh, that's right. They killed us here.
Yeah, we only lost by 20 points this time. But there were several people, and more of the staff as well had masks on. So I thought it was an improvement. But the vast majority, I'd say 85% of the people did not have masks at all. So
Yeah,
their behavior is that, laissez-faire, everything's cool, but I know it's not.
right. And I think when you go to church again, you're going to have to start wearing your masks again. Most people had, well, I would say about 50% of our church people wear masks now. But how about Carol? What's your church? How's that?
99% have no mask on.
Wow. Hmm.
Yeah, that's
Well,
a new disease, John Buchanan. It's called no mask at all.
yeah, well, our church is much more sensitive. Maybe we're older, but
No, maybe because you're there.
well, I actually, I would say about 50% of the people in the church had masks on.
Mhm. They would if we had a leader or somebody that would enforce it because they were really stringent. But then as it got relaxed, most churches, I play for 2 churches and attend another one. So all the churches, probably nobody has a mask on. I'll
Wow.
say 95% out of 3 churches I do attend regularly during the month.
Wow.
From Presbyterians to Baptists.
Well, the CDC director is suggesting that we get back to wearing masks.
And it just reminds me of that choir rehearsal in Washington State. What was that, 3 years ago? And all those people died as a result. So many got it, just from being at choir rehearsal.
Yep. Yes, I'm getting ready to go Saturday, so yeah. But I noticed that in our choir rehearsals, about 30% wear masks for choir rehearsal.
I just did Messiah on Sunday. Out of maybe 100 in the choir, I think 3 had masks on. In the audience, maybe out of 100 people, 200 people, maybe 10 or 15 people had masks on.
What about the company player?
I,
He had a mask on?
I did not have my mask on. I'm sorry. I did not wear a mask. So far,
The answer is yes, Carol, you're muted.
Were you at Shiloh?
yes, ma'am. I
Okay.
put the link in the chat if you're interested.
Okay, let's go to the next one. That's an interesting article on mouth breathing. I don't know how many people have actually breathed through their mouth. because most of us breathe through the nose. But they're suggesting that mouth breathing can cause dental caries, dry mouth, and other things like that. I wasn't aware of that before. And the question is, why would you be a mouth breather?
Yeah, this doesn't sound like something that is done consciously. I think people do this, and these are just my thoughts. You know, I feel like people do this subconsciously, and they may have some nasal passage, like blockages. You know, just they deal with sinuses and things like that, and they're not completely aware of. But yeah, I don't think anybody. You know, just my thoughts. I don't think anybody breathes out of their mouth consciously. I think it's just a involuntary reaction that some people do, maybe.
And anybody in this group a mouth breather?
I'm not a mouth breather, but as Mark was saying, if my nose is real stopped up, stuffy, I have no choice until I unstop my nose, get some kind of nose medicine to clear it out, blow my nose or something, clear it up. But if your nose is clogged up and you don't breathe through your mouth, you know, you're gonna run out of breath.
Yeah, I think Mark's analysis is right on target because when you have the nasal obstruction, then you kind of forced to.
The other thing I wanted to mention too is that I'm doing physical therapy, and we wear masks there, and so some of the exercises take your breath away. If you got a mask on, sometimes it's hard to get your breath back. You know.
I'm looking at this article closer, you know, and I wondered, you know, the difference between what they mean by, you know, daytime and nighttime, you know, because I'm sure it's probably more prevalent, you know, when you're sleeping, especially for snorers and such. And that's all. Let me just say that we do is, you know, we breathe through our mouth while snoring. And this is where, for me, you know, the CPAP mask really helps with that because it helps to clear up stuff. But also, a habit of mine has been to brush my teeth before I go to sleep each night, too. So, yeah, I think that they're talking about that now here in the article. But yeah, but it's interesting how they would come up with this. So,
I think your association of the obstructive sleep apnea is very legitimate, and because they have obstructions, and that's why they snore, and so that's interesting.
I also use a CPAP, and when I had my cold or when I had COVID before, and I couldn't breathe through my nose, I had to breathe through your mouth until it clears up. You know, so it's a problem. I mean, I want to use the CPAP, but you know, if that's the only way I can breathe, I've got to breathe through my mouth. You know.
Yeah, well, it's interesting because I hadn't really thought about it. Yeah, I think the points you brought out are very cogent. Next one, please.
It's the last one, Doc.
All right, we made it. I'm shocked.
Before you go to the last stop,
I didn't think we'd make it through it. Yes.
I was going to talk about the nose, breathing through the nose and the mouth. And the previous article said that it's unhealthy, basically, breathing through your mouth because of the germs, etc. But in our noses, we have hair sometimes. And so that's almost plays a role as a filter too.
Yeah, it's a good filter. Yeah. Yeah. It's interesting. The nasal here allow for your immune system to act on those bacteria as they enter.
So I'm going to start breathing through my nose more.
Heart arrhythmias, you know, this is probably the number one cause of people dropping dead. Cardiac arrhythmias. And that means when the heart doesn't beat properly. It may be too fast, maybe too slow, maybe irregular. And you have a lot of variations on a theme. And most people aren't aware of the consequences. Tachycardia is when your heart's greater than 100 a minute. The normal is probably between 60 and 100. Under 60 is bradycardia. And when you get below 60, then you're talking about the need for a pacemaker. When you're over 100, you have to find out why, because tachycardia can have many causes. And these are just a list of some of them. Atrial fibrillation is a situation that is often rapid and may require special treatment with sometimes you have to use heart stimulation to cause it to stop. But if you're not, you have to be on anticoagulants because it's been associated with strokes. And this is when the heart is uncoordinated heartbeat. So we usually have a regular heartbeat, but with atrial fibrillation, it's irregular. Flutter is where it beats pretty fast, but it's more organized. Supraventricular tachycardia is, again, higher than 100, but it may start and stop suddenly. But this is compatible with life. Ventricular fibrillation is not compatible with life. And if you have ventricular fibrillation, this leads to death unless you defibrillate and you have the so-called defibrillating machines that stop this from occurring. Otherwise, you would die. Ventricular tachycardia is also difficult emergency that is required electrical activity to prevent this. Otherwise, it requires immediate care. No. The slow heartbeat bradycardia, if it's less than 60, often may necessitate a pacemaker. And many elderly people who have bradycardia, when they have a pacemaker, they are much better. But a heart rate of less than 60 is dangerous. Okay, going down the line. Heart block. This is something else that may also require a pacemaker. And it's just amazing that in people over 80, the need for pacemakers is more common than you would imagine. But it may make a dramatic difference in the way somebody lives if they have a very slow heart rate and they get a pacemaker and it gets to normal, that it may normalize them in some cases. Premature heartbeats often are insignificant. They occur, your heart skips a beat, but as long as they're infrequent, it may be inconsequential unless it's persistent and long lasting. If it's persistent, then it's cause for alarm. and cardiologists will look into it to see whether it's of any. If it's only once every 10 beats or so, it's not of any consequence. But when it becomes more than one every 5 beats, then it becomes something.